spoke about building champions, but as sports orthopedic surgeons, it's for us to ensure that our champions remain champions. And before I start, I'd like to just say a quick thank you to the patients and the athletes who've consented for their names to be included into this presentation. And one more disclaimer, I know as orthopedic surgeons we love scientific details, but you'll forgive me if for medical confidentiality issues I can't get into the nitty-gritty and the details and the orthopedic details that we'd like for each of these cases. In the Rio 2016 Olympics, Vinesh Fogart, who was one of our medal prospects, sustained a very severe injury to her right knee. She dislocated it. She had to be stretchered off. She went to the local Olympic hospital there and had to be reduced. She then had to be flown back to India, where we had to do a surgery on her, a multiple ligament reconstruction. She was very keen to receive her Arjuna Award in person from the president, so we had to put her into a cast, which we normally don't do. So she got into a cast, 4 days later flew to Delhi, got her award, came back, stuck with her rehab. 7 months later, returned to wrestling, won a silver medal at the Asian Wrestling Championships. And then 2 years later, the Gold Coast Commonwealth Games in 2018, she won her gold medal. The same year in the Asian Games, she won a gold medal. And this was all done without too much ado, without too much shusha. So what are the strategies that we as orthopedic sports surgeons employ to ensure a quick and safe return to sports following injury in elite athletes? Because injuries will take place, but if we can't get our athletes back on court, on the field, on the mat really quickly, they're going to lose that competitive edge very quickly. And I think that there are 7 strategies that we employ, and I'll go through each of these. The first is advanced diagnostic medical imaging. Unlike our normal patients where, of course, you do a clinical evaluation and then based on that, maybe try a trial of non-operative treatment, and then if that doesn't work, get an MRI done, and then take it based on the merits of the case. In our elite athletes, we like to reach that diagnosis immediately. And that sometimes does mean over-investigating them, but it's best to get that diagnosis quickly. And I'll give you 2 examples. This fast bowler, left arm fast bowler, who presented to me with a vague pain in the shoulder and who had some minor neurological symptoms after bowling 10 overs and not before that. When I clinically examined him, he had almost no signs at all. But we knew that there was something wrong, that MRI was normal, and so we persisted with that diagnosis, and then it's only when we get an advanced study like a CT angio done, looking out for a rare sort of vascular cause, that we found that in that hyperabducted position, he had a pseudoaneurysm of the axillary artery, which was then causing his distal symptoms and which required a surgical excision. So sometimes we really need to push with our investigations. One more case, a badminton player with anterior knee pain. And if you look at the MRI, that MRI looks not that bad. This is not a significant chondral injury. But it's only when we get the DGEMRIC, the delayed gadolinium enhanced MRI done, that we notice that it is quite a significant injury to that articular cartilage. And when we get the T2 mapping done, we see that this is a large zone of degeneration, and on that she's got a small little chondral crack there. So this completely changes the treatment and the prognosis of return to play in an athlete. So I think the first point is making sure that you've got a quick diagnosis with the sort of investigations that you need. The second is decision making. And it's always the decision between surgical versus non-surgical. And this is a critical decision because you don't get a second chance. Unlike our normal patients where you'd give them a trial of non-operative treatment, and if that doesn't work, maybe 2 months down the line, we'll think of employing a surgical cure. In these patients, because time is short, you need to take that call early. Is my non-operative treatment certainly going to get this player back? Because if it's not, then I better employ a surgical treatment that's going to get him back faster. Take, for example, shoulder dislocations. So if you land up with an anterior shoulder dislocation, something that this player had, a classical hyperabduction injury. So he's fallen, his arm's gone into abduction with external rotation, and he's landed up with his first time anterior dislocation, which of course was reduced there by the sideline. Now, a player like this, because he's a right arm fast bowler, is going to require a surgical treatment, which otherwise we would have done a non-operative treatment for. So if it's the non-dominant arm, or if it's not a contact athlete, we may opt for a non-surgical treatment. But if it's a player for whom this is the dominant arm, it's probably best to go ahead and stabilize this early itself. And so the whole concept of primary repair for first-time anterior shoulder dislocators. And what do we do in that? Arthroscopically go down and get your anatomical repair. So you've got the torn anterior labrum there. We put in anchors, take bites through the suture, take bites through the labrum and the anterior glenohumeral ligament, and get back an anatomical repair. So if we've got a nice taut anterior glenohumeral ligament here, and we've got our concavity compression effect restored, then his static stabilizers will do their job, and his dynamic stabilizers can then be used for strength and for generation of pace, and don't really need to be working as the secondary stabilization mechanism. So sometimes for our athletes, we'll choose surgical treatment over non-operative, unlike our normal patients. Similarly, in muscle tendon tears, this fast bowler with a left-sided quadriceps, this is a central rectus tear. This is something that we might treat non-operatively in normal patients, but in our elite athletes, if someone needs to sprint, this footballer is going to get a primary repair, which is then going to enable to get back to sports earlier and prevent recurrences in the future. I remember in our residency days, we used to do adductor tenotomies under local anesthesia percutaneously, and most of our patients used to adapt well to those. But if a sportsman lands up with an adductor longus tear like this one here, and this is an avulsion straight off the bone, this is again something that we'd like to go ahead and repair primarily. So put in suture anchors, repair that adductor longus, and typically these are associated with an extension which goes into the core muscles and the rectus. This too would need to be repaired. So again, a little more aggressive approach in elite athletes as versus normal recreational athletes. And also for ankle sprains. Typically, we treat ankle sprains non-operatively in most of our patients, but in an elite athlete like this badminton player who's landed up with ATFL and a calcaneofibular ligament CFL tear, this is something that we will do a primary repair for, because this gives that player the best opportunity for restoring anatomy and therefore being able to restore and getting back to sports. The next strategy is arthroscopic surgery whenever possible. So we know that minimally invasive procedures enable our athletes to return back to sports faster than open procedures and should be used as and when possible. So take, for example, this injury. This is a goalkeeper who's got a direct impact on his proximal tibia. And you'll see that direct impacts landed up with a PCL injury. Now, if you had to do a PCL reconstruction open, that's a significantly morbid procedure that's not going to get him back for at least a year, whereas doing an arthroscopic single or a double bundle reconstruction will enable him to get back to sports in about 6 to 7 months. So as and when possible, an arthroscopic procedure. And we've seen this in multiple joints, whether it's the shoulder, the elbow, the wrist, the hip, the ankle, the knee, and other areas of the foot. It's an arthroscopic approach that will often give you a faster recovery and therefore faster return to sports. The next strategy that we use, and which has really helped change the way we treat our patients, is technological advances in the medical devices that are available. And industries ensure that we've got devices and implants that are stronger, smaller, and enable a better surgical repair. So take, for example, this young parkour specialist, and he's from Bombay itself. Parkour is a sport that's catching and becoming more popular over the years. And this is a sport that requires a lot of agility, it requires strength, and it requires you to have mobility. Now, when he lands up with an ACL tear, with an MCL tear, and a locked, transected buckle handle tear of the lateral meniscus like this, what's called a terrible triad of the knee, if you don't repair the meniscus, this patient is probably not going to get back to normalcy. Now, to repair a transected meniscus is not an easy job. You don't have much space. So this locked meniscus first needs to be reduced. And you'll see that this is a complex tear. It's torn not just radially, but also in the periphery. Now, to repair this, you need devices that are going to be all inside and which are going to fix this meniscus to the periphery first. So this is an all-inside device that achieves that. And then once you've done that, you need instrumentation that's so small that can get into that small lateral compartment, and that 1 or 2 millimeter needle can pass a suture through, and you can suture that entire meniscus back into anatomic congruity. So something that you do with a complex fracture of putting all those pieces in position, you do that with the meniscus. And for many years, we believed that the menisci did not heal. But you'll see when we do this second look arthroscopy, when we go down for his ACL reconstruction, because we've done his MCL repair and his lateral meniscus repair in the first stage, when we go down in the second stage to do his MCL reconstruction, you'll note that that's the lateral meniscus, that complex tear of the lateral meniscus that's healed out there. And it's only because the lateral meniscus is healed that we can then allow him to get back to his high demand activities. Because without that lateral meniscus, there's no way he's going to be able to get back to his training and get back to the sort of stuff that he wants. So when you've done an ACL reconstruction, a primary repair of the MCL, and you've repaired that lateral meniscus, you've gotten back anatomical congruity, and then that enables this high demand elite athlete to do the sort of stuff that he'd like to do. We do know that repairing and biomechanically bringing back structures to their original anatomy is useful, but sometimes, unless you get healing, you're not going to have normalcy. And that's where orthobiologics and regenerative medicine comes in. And take, for example, this case of a fast bowler with a locked lateral meniscus bucket handle tear. So he's got that flap of the lateral meniscus that's torn off and then locked within the horizontal cleavage tear of the lateral meniscus. Now you'll note that this meniscus tear is in the region of the popliteal zone. Now the popliteal zone has no peripheral attachment and therefore has very poor vascularity, and we know that traditionally these tears will not heal. Not only will they not heal, but they will progress with time. And this small little injury is likely to be a career-ending injury for this fast bowler. Now, knowing that, we know that we do need to repair these tears. And we can use these very nice, elegant devices to repair them and stitch them up. But if we don't get healing of the two leaves of the horizontal cleavage tear, this repair is not going to function. And that's where orthobiologics come in. So what we then use is an exogenous fibrin clot. So we take some of the patient's own blood, prepare an exogenous fibrin clot, insert that clot in between the two leaves of the meniscus. And there are a few studies now which have been published since many years which show us that these exogenous fibrin clots enhance healing. They help with the biology. They help as a chemotactic factor to enable the healing process. And once you've got that sandwiched in there between the meniscus, you'd go ahead and repair it and stitch it up. And you'll note that that's the repair, and 6 months later, your MRI shows that it's a healed repair, and this young boy went back to bowling 7 months following his surgery. Now, orthobiologics are used in multiple other sites, and we've got an entire symposium on them coming up tomorrow. Though I would warn you that this is still an evolving science, and not everything that's proposed to achieve what it says it will. So when you're using an orthobiologic, it's worthwhile to be sure that what you're using is going to be useful. The next, and I think that this is really critical, and Viren alluded to this in his presentation too, is advances in sports rehab and technology and sports biomechanics. When Neeraj Chopra tweeted this photograph after winning the Olympic gold in 2001, everyone, I think, appreciated his effort, but I think people didn't really realize the effort that went into the rehabilitation process following his elbow arthroscopic surgery. So you can do an elbow arthroscopic reconstruction, but if you can't get that elbow to get back full range, full strength and stability, and thereafter get back explosive strength, ensure that you can generate the biomechanics from the core to the shoulder and get back your throwing mechanisms, there's no way that you'll achieve what you ultimately want to achieve. And I really like the OGQ motto. It takes 6 grams to lift the worth of a nation. And you can see that this one particular throw lifted the worth of over 1 billion people. And that's possible because of the extensive rehab that he's done and the extensive biomechanics corrections that have gone into ensuring that he can throw stronger and better. And finally, a better understanding of sports biomechanics. This is something that we just didn't give attention to initially. We can restore anatomy, we can get back range and function, but if we can't get back biomechanics, then that sportsman is probably going to be ineffective. And I think the best case example for this is this fast bowler that we operated in 2014. He had an ACL tear and a lateral meniscus root tear. And of course, he underwent an ACL reconstruction with a lateral meniscus root repair. But what we had to analyze was his biomechanics, because he had not only a very awkward bowling action, but he required 20 degrees of hyperextension. And we know that hyperextension in the left, because he's a right arm fast bowler, the knee extension angle at ball release dictates how fast you're going to be able to bowl and how accurately you're going to be able to bowl. So to get back that 20 degrees of hyperextension in the left side post-surgery and to ensure that it's stable at that range is important for this fast bowler to get back to 100%. And I think that that understanding of sports biomechanics then enabled him to get back to the best that he could be. So these are the 7 strategies that we employ as sports orthopedic surgeons to ensure that our athletes can get back as quick and as safely as possible. Now, how successful actually are we in this process? So we analyzed the elite athletes, and by elite we define them as either players in cricket who represented India at any stage, or for non-cricket as players who represented India at any stage in their career. So when they had an injury and they underwent surgery, how many of these could we return to sport? That's RTS. But more importantly, how many of these could we return to performance? RTP. And we analyzed these cases that we had done from 2015 to 2021. And yes, return to sport may be very encouraging. 96% returned back to sport. But only 9 out of 10 could get back to their original level of performance as they had prior to the injury, which means that we still have to help that 1 out of 10 player, and that's where we need to really ensure we get in the coming years. So what are the things that defeat us? So injuries which are very severe, combat injuries in which there's a bony element, like this girl who had a prior ACL reconstruction, but then had a fracture dislocation of the knee with significant articular cartilage and meniscus loss. I think these are the sort of injuries where bones involved, multiple ligaments involved, meniscus losses involved, articular cartilage losses involved. I think these are the ones that still defeat us. The second ones that defeat us is our slightly older athletes with degeneration. We're seeing degenerative joint disease at a much younger age, like this 27-year-old male wrestler. You can see what his shoulder looks like, almost like a 70-year-old's. Or this 31-year-old male football player. His cartilage is completely lost on his medial femoral condyle. So degenerative joint disease is still a big, big challenge for us. And hopefully in the years ahead, we'll be able to get our slightly older athletes also back to sports with improvements in orthobiologics and maybe other technologies that come in. Viren mentioned that it's important to build champions. But if India's destiny as a sporting superpower really is to be achieved, I think our medical science, our sports science and our sports orthopedic support really can't be lacking. And I think that we've really improved over the last 15 years. We're standing on the shoulders of giants, but I think that we still have a long way to go. Thank you.